Okay, and I didn't like girl. We were on the I always have a headache too. I do not like that's just not how that works.
Like straight.
You don't have any water?
No water, maybe a little bit.
Just why didn't you fill it when you want to get water?
All right, before we get started with today's lecture, a couple of announcements. First of all, you're probably all aware that our last exam is on Monday, and that'll follow the usual format. So meet out in the hallway at 2 o'clock. We'll do the lab exam first and then move down to that same room in the next building for the lecture exam. We don't have a true final in here. This is just the 6th exam covering just this latest unit on the pelvis and lower limb. The other announcement I want to make is that I need to pack up the cadavers and prepare them for return to the University of Rochester. And if I have lots of helpers, it makes it go much, much more quickly. I can't require you to come in extra or expect you to come in extra, especially on the reading day, which is next Tuesday. But if you're available and you'd like to help out, I'm gonna be in the lab next Tuesday at about 1 o'clock to prepare them for return. If we have even half a dozen people, the whole thing can probably be done in about 45 minutes. It's just a matter of looking carefully at the cadavers, making sure there are no instruments left inside of them, making sure there are no pins in the skin, because those are dangerous for the staff over at U of R, getting rid of all the cheesecloth, and then placing the cadavers into body bags. We have a little portable table that we put next to the cadaver table, put the body bag on it, transfer the cadaver into the body bag. And we do have to do a quick cleaning of the cadaver table, because then we have to put it back onto the cadaver table. And we don't want to put the body bag back onto the table when it's all covered with grease, because there's a funeral director who's going to be coming on Wednesday to pick them up, and we don't want him to put a bunch of nasty, greasy bags back into his van. So we don't have to do like a deep cleaning of the tables, just a sort of a superficial cleaning to make sure that we don't get grease all over the bags. So anyway, that whole process, like I say, should take less than an hour, especially if I have lots of help. So I'll try to remember to remind you again, but if you are available next Tuesday at about 1 o'clock, it'd be great to have some help doing that. Okay. All right, so moving on with our next lecture, our second to last lecture in here, I want to talk about the muscular compartments of the leg, what are known as the crural compartments. The Latin word for leg is crus, but when it's turned into, when you make it plural, it's crura, or if you turn it into an adjective, it's crural. So the crural compartments are the muscular compartments of the leg. And remember, that just means the area from the knee to the ankle. There are 3 crural compartments, posterior, which you already dissected yesterday, and then anterior and lateral compartments, which you're going to dissect today. And hopefully today will be fairly quick dissection, because those 2 compartments are relatively easy. Before I actually start talking about the muscles in those compartments, though, I want to introduce the remaining bones of the lower extremity, so all of the bones of the ankle and the foot, as well as talking a little bit about the joints in the ankle and the foot, because the muscles of the crural compartments are primarily acting on the ankle and the foot and flexing and extending the toes. So here's a superior view of the foot, obviously, detached from the rest of the leg so that you can see the ankle joint. You might recall in the wrist, we had 8 little bones called carpal bones. Here in the ankle, we have 7 bones, known as tarsal bones collectively. And just like in the wrist, the carpals had individual names. All of these tarsal bones have individual names. So starting with the talus is the most superior of the bones in the ankle, meaning it sits highest. in the ankle. And the talus is the only ankle bone, the only one of the tarsals that has any contact with the bones of the leg. It articulates primarily with the tibia. So there's something that we actually call the tibio-talar joint, the joint between the tibia and the talus. But the talus also has a small articulation with part of the fibula. You might remember the inferior end or the distal end of the fibula is known as the lateral malleolus. That articulates with the lateral aspect of the talus. So that blue area that you see on the talus represents the articular cartilage that forms this tibio-talar joint with the tibia, and also forms a joint with the lateral malleolus of the fibula. The talus then rests on the calcaneus. We'll see in the next slide, when you look at an inferior view of the calcaneus, there's a little strut, a little sort of arm that projects from the medial side of the talus, a little medial side of the calcaneus, and most of the weight of the talus is resting on this little extension off of the medial side of the calcaneus. We'll see that better in the next slide. The calcaneus also has the large calcaneal tuberosity, which is your heel, and that's the insertion point for the calcaneal tendon, or what most people refer to as the Achilles tendon, which we'll talk about shortly. The talus and the calcaneus then articulate with two bones in the mid part of the foot. Medially, you have the navicular bone, which articulates with the distal end of the talus. And then on the lateral side of the foot, you have the cuboid, which articulates with the calcaneus. The navicular and the cuboid, in turn, then articulate with three bones known as cuneiform bones. And there are different ways of naming the three cuneiform bones. Here, they're simply labeled 1, 2, and 3, cuneiform number 1, number 2, number 3. But some people also refer to them as medial. So number 1 would be the most medial of the cuneiforms. Number 3 over on the lateral side would be the lateral cuneiform. And then number 2, which sits in between the others, is sometimes called the intermediate cuneiform. So you can either label them as cuneiforms 1, 2, 3, or medial, intermediate, and lateral. The three cuneiform bones articulate with the first 3 metatarsals. These are the bones that make up most of the length of the foot itself, comparable to the metacarpals that make up the flat part of the hand. And then metacarpals 4 and 5 articulate with the distal end of the cuboid. The metatarsals then articulate with phalanges, and same arrangement of phalanges that we had in the hand. The big toe is sort of comparable to your thumb. It has only 2 phalanges, a proximal phalanx and a distal phalanx. And then the other digits 2 through 5, have 3 phalanges, proximal phalanx, middle phalanx, and distal phalanx. So again, exactly the same as what we saw in the hand. Looking at these structures in an inferior view, most of this is the same. The one added structure that wasn't shown on the previous slide is this thing called the sustentaculum tali. The sustentaculum tali is this extension off of the medial side of the calcaneus that supports most of the weight of the talus. Now, if you think about it, the tibia and fibula of the leg are resting on the talus. The talus, in turn, is resting on this sustentaculum tali, this extension off the medial side of the calcaneus. That really means that the sustentaculum tali is supporting the entire weight of your body. Because, again, the leg is resting on the talus, and the talus, in turn, is resting on the sustentaculum tali. It can be fractured. There are situations where somebody could fall from a great height and land directly on their feet, and that impact could fracture the sustentaculum tali off of the medial side of the calcaneus. I've never had to illustrate that, but I know it does happen. I would imagine it's probably a rather tricky thing to repair because there's not a whole lot of bone there to reattach. The other thing that would make that very tricky to repair is if you look closely at the sustentaculum tali, you might notice there's almost like a little groove on the inferior surface of it. And if you follow that posteriorly towards the heel, there's also a little groove on the talus. All of the flexor tendons, the deep muscles from the posterior compartment of the leg, things like tibialis posterior, flexor hallucis longus, and flexor digitorum longus. Those tendons are all crossing the ankle right there and crossing under the sustentaculum tali. So the presence of all those flexor tendons there would also make it really tricky to repair this thing if it was ever fractured. Everything else is the same as what I showed on the previous slide. The calcaneus and talus articulating with the cuboid navicular, then the three cuneiforms, and then metatarsals and phalanges. A little bit different view here, looking at the foot from a medial view. In this picture, you can confirm something I said before, the fact that the talus is the most superior bone in the ankle. It's the highest bone. And of course, I get the tibia and fibula would be articulating with the talus up there. And then you see how the talus is resting on that sustentaculum tali, which extends off the medial aspect of the calcaneus. You see that big calcaneal tuberosity back here at the heel, which is the insertion point for the calcaneal tendon. The other thing you can see in this medial view is the fact that all of these bones form an arch. And it's really very similar to the stone arches that you see in architecture, particularly something like the Roman arch, which is a very broad curved arch. And if you've ever taken any architecture, maybe they talk about this in the art history classes, how you have something called a keystone that basically holds the two sides of the arch up so they don't just collapse into one another. The navicular in the foot actually functions mechanically, kind of like a keystone, right at the very center of the arch. And then there's a whole bunch of tough ligaments on the plantar aspect of the foot that help to hold the foot in this configuration. And you've probably all heard of people who have flat feet or fallen arches. Really means the same thing. Sometimes that results from a weakness of those ligaments in the plantar foot that allow that arch to kind of flatten out. Although I think more commonly, it results from a weakness of muscles like the tibialis posterior. With a weakness of that muscle, the foot actually everts a little bit, where the sole of the foot actually rotates so it faces outward. So it's not necessarily that the arch is flattened out, but people with so-called flat feet often are kind of walking on the inner side of their foot, on the medial aspect of the foot, because the foot's actually rotated outward a little bit. Right, so way back on the very first day of this class, I talked about some of the unique movements of the foot, but I'm sure you've long since forgotten about that. So let's just go over some of the names for some of the unique movements that occur at the ankle, movements of the foot relative to the rest of the body or relative to the leg. So first of all, there are two movements of the ankle that are described as flexion. And if I put my foot up here, it's kind of hard with the hiking boots on, but the motion of plantar flexion simply means that you're sort of pointing the toes away from the body, or the way I like to think of it is it's called plantar flexion. It means that the foot is flexing towards its own plantar surface, towards the bottom of the foot or the sole of the foot. That is referred to as flexion because embryologically, that motion of pointing the foot away from the leg is the equivalent of flexing the wrist. So we call it flexion because it's sort of, like I say, embryologically, it's comparable to flexion of the wrist. The other motion, the opposite motion, called dorsiflexion, is where you move the foot towards its own dorsal surface, and hence the name dorsiflexion. So it's almost like you're trying to bring your toes towards your leg. That's called flexion because in that motion, you're decreasing the angle between the foot and the leg, which is really the definition of flexion. With flexion, you're always decreasing the angle between two parts, like flexion of the elbow, you're decreasing the angle between your forearm and your arm. So decreasing the angle between the foot and your leg is called flexion. So both of these movements are called flexion, but for very different reasons. One, because it really meets the normal definition of flexion where you're decreasing the angle between two body parts. In the other case, it's called flexion because it's comparable to the flexion of the wrist from an embryological point of view. The other pair of motions that are illustrated here called inversion and eversion. These are even harder to show with the boots on, but yeah, we'll do this. So inversion is a kind of rotation where the plantar surface of the foot turns in such a way so that the plantar surface or the sole of the foot is facing inward. And then the opposite of that is eversion, which definitely can't do with the boots on, where I'm trying to turn my foot so that the plantar surface or sole of the foot is facing out laterally away from the midline. So try that with yourself, sort of lift up on the medial side of the foot, raise the big toe and push the little toe down so the plantar surface faces medially inward towards the body. And the opposite motion, pushing the big toe down and the little toe up so that the plantar surface faces outward, away from the body. We'll talk about the muscles that are responsible for all these movements. So there are a bunch of different joints in the ankle and in the toes, similar to the various joints that we saw in the wrist and in the hand. So I've already mentioned this thing called the tibio-talar joint. This is the main joint that we think of when we think of what we call the ankle joint. It's the joint formed primarily between the distal end of the tibia and the talus, but it's also formed by the lateral malleolus of the fibula, articulating with the lateral side of the talus. And this is where the majority of dorsiflexion and plantar flexion take place. So both of those flexion movements of the ankle. So either bringing the toes towards the leg or pushing the toes away from the leg. Dorsiflexion and plantar flexion occur primarily at that tibio-talar joint. There's a second joint in the ankle region known as the subtalar joint. And this is the joint that's formed between the talus and the calcaneus. Remember, the talus is resting on the calcaneus. In particular, it's resting on this thing called the sustentaculum tali. And that forms a joint called this subtalar joint, meaning it's, subtalar means it's below the talus. This joint allows some rotational movement that contributes primarily to inversion and eversion. It's sort of a twisting motion of the ankle that either inverts the plantar surface of the foot or everts the plantar surface of the foot. That subtalar joint is not involved at all in flexion or extension of the ankle or dorsiflexion or plantar flexion of the ankle. Next, there's a joint called the mid-tarsal joint. And this is really two joints in one. It's the joint between the talus and the navicular, and also the joint between the calcaneus and the cuboid. But together, those two joints are referred to as the mid-talar joint. It's kind of similar to something we call the mid-carpal joint between the proximal and distal row of carpals in the wrist. This mid-tarsal joint contributes a little bit to dorsiflexion and plantar flexion, and also contributes a little bit to inversion and eversion. So it doesn't move a lot, but it adds a little bit to both of those other motions. The next group of joints are called the tarso-metatarsal joints. So a set of joints between all of the distal tarsal bones and the proximal end of the metatarsals. This is comparable to a set of joints we had in the hand called carpo-metacarpal joints. And I don't know if you remember here in the wrist and in the hand, that the first carpo-metacarpal joint was down at the base of the thumb. It's back where the wrist meets the first metacarpal with the thumb. That first carpo-metacarpal joint was relatively mobile. The others were not. The others hardly moved at all. And you can verify that by grabbing the metacarpals in the middle of your hand and try to wiggle them, and they don't move very much. Same thing is true here. In fact, it's even more true of these tarso-metatarsal joints, that none of them are mobile. Even the first one of the big toe is not mobile. So these joints hardly move at all. They're anchored very tightly by a bunch of tough ligaments that prevent any kind of motion. So the next joints that actually allow any real significant motion are the metatarsophalangeal joints. So there are 5 sets of metatarsal phalangeal joints between the distal end of the metatarsal and then the proximal phalanx of each toe. These joints are capable of 2 different kinds of motion. First of all, you can have flexion extension at these joints, so you can flex your toes and you can extend your toes, but you can also abduct and adduct the toes. So abduction of the toes would refer to spreading the toes apart, similar to the way we spread our fingers apart in our hand. And then adduction of the toes would be the opposite, of bringing them back together towards the midline of the foot. So metatarsal phalangeals can flex and extend, as well as abduct and adduct. And then we have a whole bunch of interphalangeal joints. Since the big toe only has 2 phalanges, there's only a single interphalangeal joint. The other toes all have 3 phalanges, proximal, middle, and distal. So you have 2 sets of interphalangeal joints. You have a set of proximal interphalangeal joints or pip joints, and a set of distal interphalangeal joints or dip joints. Again, exactly the same thing we saw in the hand. Yeah, Brianna. Abduction would be spreading, because abduction always means moving away from the midline. And then adduction would be bringing them back towards the midline. All of these interphalangeal joints, the IP joint of the big toe, and then the pip and dip joints in the other digits, are capable of just flexion and extension. These joints don't abduct or anything. They just flex and extend. So here's a summary of all the joints we just talked about. I won't go through it in detail because it really just repeats everything I just said. But at least it's all summarized for you in text form in the PowerPoint slides on my courses. All right, so let's talk about the muscular compartments of the leg that are responsible for all of those different motions that we just talked about. So if you look at a cross-section through the leg, you see that there are 2 bones, of course, in the leg, the much larger tibia and the much smaller fibula. Notice the cross-sectional profile of these. I mentioned this last time when I first introduced the tibia and fibula, that they are not round cylinders. They actually are more triangular in cross-section with 3 flat surfaces. I think you can see that pretty clearly here. The tibia has an anterior medial surface, an anterior lateral surface, and then a posterior surface, which, I mean, they may be a little bit curved, but they're relatively flat. It's definitely not a perfect cylinder. And even the fibula has roughly that triangular profile as opposed to just being cylindrical. So it's an important thing when you're illustrating these bones. So then surrounding those bones are 3 muscular compartments. We dissected the posterior crural compartment yesterday, and these muscles do several things. Some of the actions are listed here, although it's not a complete list. These are the muscles that are going to plantar flex the foot. So things like gastrocnemius and soleus are going to pull up on the calcaneal tuberosity, through that big calcaneal tendon. So you pull up on the heel, that rotates the foot the other way, so the toes move away from the leg. So that would be plantar flexion. Also, the muscles that flex the toes. So flexor hallucis longus and flexor digitorum longus, muscles that flex the toes. And also the tibialis posterior muscle is the primary muscle responsible for inversion of the foot, lifting up on the medial side of the foot to rotate the plantar surface so it faces inward. Something that's not mentioned here is that the gastrocnemius, since it originates on the femur, is not only crossing the ankle joint, but it's also crossing the knee. So the gastrocnemius actually plays a role in helping to flex the knee. It works with all of the hamstring muscles to help flex the knee. All of the muscles in the posterior compartment are all innervated by the tibial nerve, which you saw in lab yesterday. And I'll talk about that more in a bit. Then there are 2 other compartments, which is what you're going to dissect today. These are both much smaller muscular compartments with fewer muscles in them. So there's the anterior compartment, which is kind of anterior, but it's sort of anterolateral. You notice that it sits lateral to the tibia, kind of between the tibia and the fibula. The muscles in the anterior compartment of the leg are the muscles responsible for dorsiflexion. So these are going to lift up on the foot and rotate, pull the foot towards the leg to dorsiflex the foot. Also, there are two muscles in here that extend the toes. We'll see in a minute. There's an extensor hallucis longus that extends the big toe, and an extensor digitorum longus that extends the other 4 digits. All of these muscles in the anterior compartment are innervated by something called the deep fibular nerve, or deep branch of the fibular nerve. And then finally, there's a small lateral compartment that sits just lateral to the fibula. This contains 2 muscles, both of which do the same thing. Both of these muscles in the lateral compartment are going to lift up on the lateral edge of the foot to evert the foot. You lift up on the lateral edge, it rotates the plantar surface so it faces outward. So that would be eversion. And these 2 muscles are both innervated by the superficial fibular nerve. All right, so let's look at each of these. Actually, let's talk about the nerves first. I think in the order of my slides, I talk about the nerves and the arteries first, and come back and have the muscles on, which is a little backwards from the way I usually do things. So here are the major nerves in the leg. So we've got the sciatic nerve, which is up in the thigh. And usually that sciatic nerve is going to split somewhere around the level of the popliteal fossa, the area right behind the knee. It's going to split into a tibial nerve, which is then going to continue and run all the way down through the posterior compartment of the leg, eventually cross the medial side of the ankle and end up on the plantar surface of the foot. We'll see that again on Thursday when we talk about the structures in the plantar foot. The other branch from the sciatic nerve is called the common fibular nerve. And this is wrapping around the lateral side of the knee. There's another word in there in parentheses, peroneal. This is how I actually learned this nerve. When I took anatomy, we called this nerve the common peroneal nerve. And there's some muscles too that we're going to talk about called fibularis longus and brevis muscles. I learned those as peroneus longus and brevis. I don't know why the name changed or when that happened exactly, but it seems like all the books now have abandoned the use of the word peroneal in favor of fibular. Maybe it's just easier to remember because the fibula is the lateral bone in the leg. And so calling everything on the lateral side of the leg, fibular something, maybe they just thought that was easier to remember. So the tibial nerve, going back to the tibial nerve for a second, is going to innervate everything in the posterior compartment. So all of the superficial and deep muscles in the posterior compartment. And then when it ends up on the plantar surface of the foot, it splits into a pair of nerves called the medial and lateral plantar nerves, which innervate everything on the sole of the foot, all of the structures in the plantar foot. The common fibular nerve, we'll see where that goes in the next slide. It's going to wrap around the knee and then split again. So here we're looking at kind of a sort of anterior lateral, sort of oblique view of the leg. You see the patella up there and tibial tubercle, so that's kind of anterolateral and a sort of anterior view of the foot here. You see that common fibular nerve now wrapping around from the back of the knee, wrapping around towards the front of the leg, and at some point it's going to split into its superficial and deep branches. So superficial fibular nerve is going to innervate the 2 muscles in the lateral compartment of the leg, and then it's going to continue as a sensory nerve down onto the dorsum of the foot, where it's the primary sensory nerve for the dorsal surface of the foot. The deep fibular nerve is going to enter the anterior compartment of the leg, and it's going to innervate everything in the anterior compartment of the leg. Then the deep fibular nerve will cross the ankle, where it's going to innervate two tiny muscles on the dorsal surface of the foot, which we'll talk about in a minute. And then it continues as a sensory nerve, but it's sensory only to a tiny area of skin, an area about the size of a nickel or a quarter that lies between the first two toes. So it does have a sensory component, it's just really small. So here's the same picture that I put up on the board for you in lab, showing the branching pattern of the nerves, and then we'll come to the arteries in a minute. You got sciatic nerve splitting into tibial nerve, which supplies everything in the posterior compartment. That's eventually going to cross the ankle and split into medial and lateral plantar nerves that innervate everything on the sole of the foot. Common fibular nerve, it's going to split into superficial and deep. Superficial fibular nerve innervates the structures of the lateral compartment. Deep fibular nerve innervates everything in the anterior compartment. What I didn't show here is that deep fibular nerve, actually both of these continue into the foot. Superficial fibular nerve is a sensory nerve to most of the dorsal surface of the foot. Deep fibular nerve innervates just this small area between the first two toes. So we've also got three major arteries in the leg, but as I mentioned in lab yesterday, the naming of these three branches, unfortunately, is not the same as the naming of the nerves. So we've got a big artery called the popliteal artery, which is located in the back of the knee. Remember that that's the continuation of the femoral artery. So the femoral artery in the thigh passes through a little opening called the adductor hiatus. It's a hole basically in the adductor magnus muscle. And as soon as the femoral artery passes through that adductor hiatus, it changes names to become popliteal artery. So that's the big artery in the back of the knee. That popliteal artery is then going to split into a total of three branches. The first branch is called the anterior tibial artery. It branches off the front of the popliteal artery, and it's going to poke through the interosseous membrane. So there's a little tiny black circle up there in the upper right, showing how the anterior tibial artery is going to poke through the interosseous membrane and eventually end up in the anterior compartment of the leg. If you follow that anterior tibial artery down through the anterior compartment of the leg, eventually it crosses the ankle joint and changes names to the dorsalis pedis artery. This is the artery, the primary artery to the dorsal surface of the foot. So after the anterior tibial branches off, the rest of the popliteal artery splits into a fibular artery, which is in the posterior compartment on the lateral side, and eventually that just kind of ends. And also a posterior tibial artery, which also continues through the posterior compartment and crosses the ankle and eventually splits into medial and lateral plantar arteries on the plantar surface of the foot, the sole of the foot. So supplying all of the blood supply to all the structures on the plantar foot. Something I've always found interesting about these arteries is that anterior tibial artery is in the anterior compartment. Posterior tibial artery and the fibular artery are both in the, excuse me, did I say that right? And anterior tibial artery is in the anterior compartment. Hopefully I said that right. If not, that's the way it should be. Anterior tibial artery and anterior compartment. Posterior tibial artery and the fibular artery are both in the posterior compartment. There is no artery in the lateral compartment of the leg. There's a nerve in the lateral compartment of the leg that innervates the muscles of the lateral compartment, but there is no artery. The muscles of the lateral compartment have to get their blood supply from small branches of these other vessels.
So the little parentheses, is that where they are in the body or where they're supplying?
That's where they are in the body, not necessarily what they supply. It's not like a nerve where a nerve definitely innervates a particular muscle.
Okay.
With arteries, it's a little more vague about what they actually supply. All right, so looking at the individual compartments themselves, starting with the posterior compartment, when you first skinned the posterior compartment, the first muscle you see is the gastrocnemius. So gastrocnemius has two distinct heads, two origins from the medial and lateral condyles of the femur. Those two heads then join together to form a single muscle belly, and they join together to contribute to the Achilles tendon or calcaneal tendon, which inserts on the calcaneal tuberosity. So the origin is simply medial and lateral condyles of the femur. Insertion is calcaneal tuberosity. I'm not going to. I'll just summarize the innervation of the whole posterior compartment. Everything in the posterior compartment is innervated by tibial nerve, so that includes the gastrocnemius. The gastrocnemius can do two things. Probably its most important function is plantar flexion of the foot. So when you pull up on that calcaneus, the rest of the foot rotates the other way, away from the leg. So that would be plantar flexion. But because the gastrocnemius is originating on the femur, that means it's also crossing the knee joint. And so it can play a role in helping to flex the knee as well. In lab, you cut the two heads of the gastrocnemius, not quite as much as this. You didn't cut them off, but you did cut the heads of the gastrocnemius and reflected them out of the way. And that revealed a few deeper muscles. The biggest of those is the soleus. The soleus has a very broad origin from the tibia, the fibula, and the interosseous membrane. So basically the whole back surface of the leg. And it also contributes to the formation of a calcaneal tendon, so it has its insertion on the calcaneus. This muscle has just one job, which is plantar flexion of the foot. The soleus doesn't originate on the femur, so therefore it can't cross the knee joint. It doesn't cross the knee joint, so it can't do anything to the knee. It's only crossing one joint, and that's the ankle. So it's going to lift up on that calcaneus to plantar flex the foot. A couple of small muscles located back here. There's a muscle called the plantaris. It has its origin from the lateral condyle of the femur, so right alongside one of the heads of the gastrocnemius. And has this, it's a tiny little muscle and has a very long skinny tendon that travels down and merges with the other tendons to contribute to that calcaneal tendon. So it's crossing the ankle and inserting on the calcaneus, so it can help to plantar flex the foot. And it is actually crossing the knee joint because it originates on the femur. So that means it can also help to flex the knee. It's just that it's so tiny by comparison to all the other muscles that really it does virtually nothing. But theoretically, it can participate in those two motions. I'm sorry?
Sorry for interrupting. Don't some people just not even have it?
Yeah, some people just don't even have it. Similar to the palmaris longus in your forearm, another muscle that's disappearing in some percentage of the population. The last muscle that's shown here is a muscle called the popliteus, which is originating also from the lateral condyle of the femur and crossing diagonally up near the knee joint to insert on the tibia. So this muscle is only crossing the knee joint. And it can play a small role, a very small role in helping to flex the knee. But it actually has another more important job. So if you need to stand for long periods of time, rather than using your leg muscles to exert a lot of energy to just help keep you upright, you can kind of push your knees backwards and sort of lock them in place. And so your knees sort of go into this locked position that allows you to stand upright for long periods of time without having to exert any energy. That locking mechanism, when you push your knees back and they get into that kind of locked position, the tibia actually rotates very slightly relative to the femur to help achieve that locked configuration. When you want to unlock your knee, you actually have to forcefully rotate your tibia very slightly back into its normal position. That's what the popliteus does. Its primary job is to create a very slight rotational movement of the tibia relative to the femur to help unlock the knee joint.
Which way is it?
So it would really be a medial rotation. So if you imagine what the foot is doing, the toes would be rotating inward a little bit medially. I mean, very slightly, like imperceptibly. And in fact, usually when you do that, your feet are planted firmly. So your feet really aren't moving, but the tibia still does that sort of medial rotation very slightly. Yeah,
Is it also helping lock your knees or
No.
just unlock?
just unlocking. You'd need another muscle to rotate the tibia in a different direction. So you'd have to have a different muscle with completely different fiber direction. And you don't need that. Just the act of pushing your knees back pushes them into that lock position. But to get them to unlock, you have to actually rotate the tibia a little bit. All right, so after looking at those superficial muscles, you then did a deep dissection of the posterior leg. So you cut the calcaneal tendon distally, and you detached the soleus with the gastrocnemius kind of connected to it, and reflected the gastrocnemius out of the way. In this Netter painting, he's completely removed it, which you didn't do. But still, this shows the deep structures in the leg. So there are three deep muscles in the posterior compartment of the leg. The most lateral of these muscles, which would be on the right side of the slide, is called the flexor hallucis longus. In Latin, I think it's Latin, it might be Greek, but one of those ancient languages. The hallux is the big toe. So anything related to the big toe is called something hallucis. And note the spelling of it. I need a pen. Where's my markers? For some reason, it's one that people frequently misspell. Somewhere in here. For some reason, everybody wants to spell it like this. Hallicus. That's not it. It's hallucis. Hallucis. Okay, so flexor hallucis longus has its origin from the posterior surface of the fibula. Its tendon is going to cross the ankle down into the foot, and you can just barely see the continuation of its big tendon over here on the medial side of the foot.
So it originates from the fibula?
From the fibula. And it's going to continue all the way out to the distal phalanx of the big toe. And it's going to simply flex all of the joints of the big toe. Yeah, right.
So just on your muscle chart.
Yep.
For the flexor hallucis and digitorum.
Yep.
It says tibia and fibula. Is that another, like we can say just fibula or?
Yeah, that's probably a typo on my part in the muscle chart, that the flexor hallucis longus is originating from the very lateral most part of the posterior compartment, which would be the fibula. Maybe there's a little bit originating on the tibia, but it's almost entirely from the fibula. And then for the digitorum, that's originating from the most medial part of the posterior compartment, which is the tibia.
Oh, okay, so, okay, yeah, they're grouped together, so I'm just.
Okay.
Another question?
Yeah.
Is big toe acceptable on the exam?
Yeah, I guess big toe is acceptable, just like thumb would be acceptable.
Yeah.
in the hand.
Little toe, like pinky, or pinky toe.
Yeah, I mean, I think I let you say like index finger, middle finger, ring finger, et
Yeah.
cetera, in hand, so, I mean, just be aware that they are numbered 1 through 5.
Right.
I'll think pinky toe, little toe, big toe. The other ones don't have names, so you're kind of stuck with numbering them if I ask about one of those. Ring toe. All right, so flexor hallucis longus originating primarily from the posterior fibula, crossing the ankle and going all the way up to the distal phalanx of the big toe to flex all the joints of the big toe. So then way over on the medial side of the posterior compartment of the leg is flexor digitorum longus. And this is originating from the posterior surface of the tibia. And its tendon is also then going to cross the ankle. And you can just barely see it down here. It splits into 4 tendons. They're going to travel out to digits 2, 3, 4, and 5 and insert on the distal phalanx of digits 2 through 5. And it's going to flex all of the joints of those digits. And then the final muscle in the posterior compartment, called tibialis posterior. If you look closely at this Netter painting, you'll see that he's painted a little hook in here that's actually holding the flexor hallucis longus out of the way. That's so that you can actually see tibialis posterior. It actually originates very deep in the posterior leg, and much of it is actually hidden by those other 2 flexor muscles, and it's only down at its distal end that it starts to emerge from between those other 2 muscles. So tibialis posterior that one really is originating from tibia and fibula and interosseous membrane. It's kind of, in between those 2 bones and even from the membrane itself. And then if you follow it down into the ankle, it's inserting on, gosh, is it the navicular or the cuboid? Can't remember what I put in the chart.
This is navicular, cuboid, and metatarsus.
Okay, all right. So that's why I couldn't remember which it was, because it's both, and it's metatarsus. The tibialis posterior it may play a small role in plantar flexion, but really its primary job is inversion of the foot. Meaning it's going to lift up on the medial side of the foot, rotate the plantar surface of the foot so the plantar surface faces inward. And again, all these muscles are all innervated by tibial nerve.
Is there any mechanism that lets you move your pinky toe independently?
There is a flexor digiti minimi.
Okay.
Yeah. And there's also an abductor digiti minimi. So you can flex and abduct your pinky toe independently of the others.
You guys see
Oop.
those?
Yeah.
But they're not in the posterior department, even though.
They're on the plantar foot.
Oh.
We'll see those down in the sole of the foot. I'm sorry, was there another?
Never mind that.
Okay.
I'm good.
All right, so also shown on this slide are the nerves and arteries of the posterior compartment. And the nerve is simple, it's just the tibial nerve, which innervates everything in the posterior compartment, but then it continues, crosses the medial side of the ankle, and then splits into medial lateral plantar nerves that supply innervation, everything on the sole of the foot, plantar foot. The arteries, you can see the popliteal artery up there behind the knee. It gives off this anterior tibial artery, which you can just barely see here, but it's poking through the interosseous membrane to eventually enter the anterior compartment of the leg. Then the rest of the popliteal artery splits into a fibular artery running down the posterior compartment and then just kind of fizzles out and ends. And then a posterior tibial artery, which continues all the way through the posterior compartment, crosses the medial side of the ankle, enters the plantar foot where it splits into medial and lateral plantar arteries. All right, so today in the lab, you're going to dissect the other two compartments of the leg, anterior compartment and lateral compartment. And as I said before, these should be fairly easy dissections. So you're going to skin the anterior surface of the leg. And one thing you'll notice is that on the anterior medial side of the leg, the tibia lies right under the skin. There's no muscle or anything covering that surface of the tibia. This is one of the few areas in the body where a bone is exposed right under the skin with no muscle covering it. There are very few places like that in the body where bone is exposed. So when you're illustrating the body, especially in the limbs, but really anywhere on the body, there are very few places where you actually see bones fully exposed. There are almost always a muscle that inserts there and then another muscle that originates there. So as soon as one inserts, the other one originates. Another place where you see bone exposed is right along the ulna, along the medial aspect of the forearm, from the olecranon down to the wrist. And then, of course, ribs probably be the other major area where you see bone exposed. Just a little bit lateral to the tibia is where you're going to run into the first muscle in the anterior compartment, called the tibialis anterior. This is originating primarily from the tibia itself. But it also has another origin that's a little unusual that actually makes this muscle a little tricky to dissect out. It has part of its origin from its own fascia. So there is crural fascia covering the entire leg, and part of the tibialis anterior is originating from the deep surface of that crural fascia itself. The reason that makes it a little tricky to dissect this area is you literally have to cut away the crural fascia and cut it away from the origin of this muscle in order to actually expose the muscle. If you follow it down to its insertion, this is also inserting primarily on the navicular bone in the foot. And this is the primary muscle responsible for dorsiflexion of the foot. It's going to lift up on the top surface of the foot and rotate the foot, turn the foot towards its dorsal surface, towards the leg. Just lateral to tibialis anterior, we have the long extensors of the toes. There's an extensor digitorum longus, which is the most lateral muscle in the anterior compartment. That's originating primarily from the fibula. Maybe a little bit from the interosseous membrane and the tibia as well, but primarily from the fibula. And if you follow its tendon distally, you'll see that it splits into 4 tendons, which continue out to digits 2 through 5. Again, I forget exactly how I worded it in the muscle chart, but does it say extensor expansion of digits 2 through 5? Yeah, okay. So you might remember that from the fingers, that each finger had something called an extensor expansion, which is sort of a hood of tendon on the dorsal surface of each finger. So we have the same thing with the toes. So the 4 tendons of extensor digitorum longus are all inserting into those extensor expansions of just digits 2 through 5. Then kind of squeezed in between tibialis anterior and extensor digitorum longus, we have the extensor hallucis longus, which is also originating from tibia, fibula, and interosseous membrane, and then sent its tendon out to the distal phalanx of the big toe. So these are going to extend the joints of all the toes. The extensor hallucis longus is going to extend all the joints of digit 1, the big toe, and extensor digitorum longus is going to extend all of the joints of digits 2 through 5. Notice that their names, extensor digitorum longus, extensor hallucis longus, that means that there must also be a brevis. We'll come back to those in a minute, but the brevis muscles are actually down here on the dorsum of the foot, little tiny muscles. These three muscles in the anterior compartment are all innervated by the deep fibular nerve, one of the two branches of the common fibular nerve. We zoom in on the dorsal surface of the foot. You can see those tendons coming down from the anterior compartment of the leg. So over here on the medial side, which is on the right side of the picture, we have that tibialis anterior tendon coming down around the medial side of the foot and inserting primarily on the navicular, but also one of the cuneiforms and metatarsals. That's the muscle that's going to lift up on the medial side of the foot to invert the foot and also to dorsiflex the foot. And you can see extensor hallucis longus tendon coming down to the distal phalanx of digit 1, the big toe, to extend all the joints of the big toe. And then extensor digitorum longus splitting in 4 tendons, traveling out to the extensor expansion of digits 2 through 5 to extend all of the joints of digits 2 through 5. Now there is one other tendon on here, which I've always found to be kind of an odd thing, kind of an odd muscle or tendon. Something on here labeled fibularis tertius, and it's labeled specifically fibularis tertius tendon. In a minute, we'll see that there are 2 muscles called fibularis muscles in the lateral compartment. This is called fibularis tertius because it's considered sort of the third fibularis muscle. That's literally what tertius means. It means the third one. But it's not part of the lateral compartment. It's actually a tendon that branches off of the extensor digitorum longus. So it's sort of part of the extensor digitorum longus, but it doesn't extend the toes. Instead, it's inserting on the base of the 5th metacarpal, or excuse me, metatarsal, which means it's going to pull up on the lateral side of the foot, which means it's going to help to invert the foot. So some books that I've seen describe it as being just sort of an extra tendon off of the extensor digitorum longus, but I've seen other books that identify it as being its own separate muscle. And yet every time I've ever seen it in anatomy lab, it always looks like it's just part of extensor digitorum longus. I don't think I've ever seen it as like a distinct muscle belly. Also, you can see the nerves and arteries to the dorsal surface of the foot. So way up in the anterior compartment of the leg, the top left label up there says anterior tibial artery and deep fibular nerve. So that anterior tibial artery, that's the artery that pokes through the interosseous membrane and is now running down the anterior compartment. If you follow that anterior tibial artery down, it crosses the ankle joint, and as soon as it crosses the ankle joint, it changes names to become that dorsalis pedis artery, which literally means the dorsum of the foot. It's the artery to the dorsal foot. The nerve running right alongside of it is the deep fibular nerve. So again, that's one of the branches of the common fibular nerve that supplies everything in the anterior compartment of the leg. That deep fibular nerve crosses the ankle. It doesn't change names though. It's still called deep fibular nerve. That's what also innervates these muscles on the dorsal surface of the foot, which I'll come back to and talk about in a minute. I realized I just forgot to talk about those. So deep fibular nerve is innervating these little short extensor muscles on the dorsum of the foot. And then deep fibular nerve then continues from there to this little space between digits 1 and 2 to innervate a small area of skin between the first 2 digits. So I forgot to come back and talk about the short extensor muscles. There are 2 little short muscles that extend the toes that are actually originating on the dorsum of the foot. And I don't think I asked you to know their origins. There's an extensor hallucis brevis, which is helping to extend the big toe. and then an extensor digitorum brevis that splits into, I think only 3 tendons. It helps to extend digits 2, 3, and 4. But usually when it's illustrated, they don't show a 4th tendon going to digit 5. And I think when I've seen them in lab, they never have a tendon going to the 5th digit. All right, final compartment of the leg, which you'll also be dissecting today, is the lateral crural compartment or lateral compartment of leg. And this contains just 2 muscles, the fibularis longus and fibularis brevis, formerly known as peroneus. At first, these muscles can be very difficult to distinguish from one another because they lie right on top of one another. The fibularis longus is a little bit superficial. Fibularis brevis is just deep to it, and their tendons actually run together, at least initially, their tendons are together. So when you find these muscles, what you have to look for is just a very subtle little separation between their tendons. And you can actually get a probe in there and eventually actually separate the longest tendon, which is more superficial, from the brevis tendon, which is a little deeper. And then you can actually distinguish the 2 muscles from one another. Both of them originating from the fibula on the lateral side of the leg. And they're going to cross the ankle on the lateral side. These are, by the way, these are the only muscles that cross the ankle on the lateral side. Everything else from the posterior compartment is crossing the ankle on the medial side. The reason for the different names, longus and brevis, you can probably guess one's longer and one's shorter. If you follow the brevis tendon down, which is the deeper tendon, it actually ends up stopping right here at the base of the 5th metatarsal. So it's inserting on the metatarsal of the 5th digit, the pinky toe. The fibularis longus, on the other hand, you kind of lose sight of it right here. It looks like it's just sort of disappearing under the foot. It's actually going to cross on the plantar surface of the foot all the way across to the medial side to insert on the base of the 1st metatarsal of the big toe. So when you look at it here, it looks like the tendons are the same length. But what you have to realize is that that longest tendon is crossing diagonally all the way across the sole of the foot, all the way over to the medial side, to the 1st metatarsal. Right? So it is significantly longer, a good 3 inches longer. So that's the difference in names. Yeah.
And the brevis attaches on the 5th metatarsal?
Right. Brevis attaches on the 5th metatarsal, longus on the 1st metatarsal. They're both innervated by the superficial fibular nerve. And this little branch right here that you see poking out between the 2 muscles, that is what's left of the superficial fibular nerve. Eventually, that superficial fibular nerve would actually continue down and become a sensory nerve on the dorsum of the foot. But this is right after it finishes innervating these 2 muscles. And both of these muscles do the same thing. Even though they have different insertions, the effect of the 2 muscles is the same. They're both going to lift up on the lateral side of the foot, which is going to evert the foot. So here we see some of the structures on the dorsal foot, as well as these 2 fibularis muscles on the lateral side of the ankle and foot. Again, you see extensor hallucis longus going out to the big toe, the 4 tendons of extensor digitorum longus going to digits 2 through 5. This sort of problematic extra tendon, the 3rd fibularis muscle tendon, which is really just part of extensor digitorum longus as far as I'm concerned. And then fibularis brevis from the lateral compartment inserting on the 5th metatarsal. Fibularis longus sort of disappearing under the foot and crossing all the way over to the other side to insert on the 1st metatarsal. All right, last thing I want to talk about today is a medical condition that involves a lot of these nerves that we've just talked about. This is the condition of sciatica. And to put it simply, sciatica is a type of pain in the lower limb that tends to radiate along the entire limb, often starting in the low back and extending all the way down to the toes. Typically affecting just one dermatome, one specific dermatome. So it's usually caused by compression of one of the spinal nerves, which is why it's typically restricted to one dermatome. If you compress one spinal nerve as it exits the vertebral column, then all of the symptoms you feel are going to be felt only in that dermatome supplied by that spinal nerve. So the most common by far nerves or spinal nerves that are affected in sciatica are L4, L5, and S1. And the thing that's compressing them usually is a bulging or herniated intervertebral disc. So you've got a bulge or herniation of one of the intervertebral discs that is compressing one of these spinal nerves as it's passing through the intervertebral foramen, exiting the vertebral column. So the pain that you feel follows the entire dermatome supplied by that spinal nerve. And these typically start in the low back, just below where the spinal cord itself would end. And then the pain is sensed then extending down through one of the buttocks, into the thigh, into the leg, and out into the toes. The exact location depends on exactly which nerve it is, which dermatome is being affected. And typically, I didn't mention it here, but typically it's on one side. So usually when you have a bulge or herniation, it's bulging or herniating to one side or the other. So it's likely to compress the spinal nerve only on the left or only on the right. So people with sciatica will typically have symptoms in one lower limb. Eventually, I suppose they may get it in both, but at least initially, it often just starts out in one limb or the other. Now, because you're compressing a spinal nerve, not only are you causing pain in the dermatome that's supplied by that nerve, but you can also end up with muscle weakness too, because you may be cutting off the flow of action potentials through the motor neurons that are supplying some of the muscles. It doesn't usually result in complete paralysis of any muscle, because most muscles are supplied by more than one spinal nerve level, but there could still be significant weakness of the muscles. I speak from personal experience. I had a bad bout of sciatica in 2004. Most painful thing I've ever felt in my life. You ever want to see a grown man in tears? It was really painful. I got to the point where, standing was bad because you're putting more weight on the vertebral column, but even laying down was bad for some reason. I had to sleep in a chair for like a week or longer, waiting for surgery. But I actually had to have an MRI and went to a neurosurgeon and actually had surgery on it. Now, it turns out in my case, it was not a disc bulge or herniation. I assumed it was. I went to see the neurosurgeon and said, I have compression of my L4 nerve on the right. I knew the dermatome. And so he sent me for physical therapy, which made it much worse. And so I went back to him, and so we did an MRI, and I'll never forget his diagnosis. He said, "You have big man, small hole disease." I thought, that sounds really weird. So he's referring to the fact that I am still, large and carrying more weight than I should. I was actually a lot heavier back then even. And he said, apparently I had congenitally narrow intervertebral foramina, which had never heard of that before. So hence big man, small hole. just makes you a lot more susceptible to narrowing of the intervertebral foramina, even without an actual disc bulge or herniation. So he went in there with a drill and just did a little roto-rooter and just made the hole bigger, and I came out and I was fine.
Immediately better.
Immediately, yeah.
So is the foramina that was compressing the
The foramen?
Is that what you said?
Yeah, the intervertebral foramen, right, yeah.
Okay.
Because it was narrow, but there was probably some bone growth, or they call it spondylitis, where there's excess bone growth, so bone spurs that made it even narrower than it was to begin with.
Do they ever do that for someone who has a herniated disc? Because wouldn't like increasing the foramina kind of let the nerve like move over?
Yeah, now if somebody has a full-blown herniation, they wouldn't just do that. You've got to get rid of the herniation. If there's a mild disc bulge that's causing compression, sometimes they do what's called a laminotomy, where they just remove part of the lamina that just gives a little bit more room for the nerve to breathe.
Why did he send you for physical therapy if he knew that there was like?
I can't remember if we had done the MRI before the PT or not. I guess physical therapy is considered the usual, like, less invasive treatment. And maybe for some people it helps. For me, it sure didn't.
How would physical therapy help with like a bulging disc?
Yeah, see, if it was a bulging disc, there's no way that PT would help that. I mean, I guess you can do, I don't know, some stretching and bending exercises that might take some of the pressure off the disc so it doesn't bulge as much, although it seems like as soon as you stand back up, it's just gonna
Maybe
press it
that
some
feels
more.
like more of like a preventative measure. Like,
Yeah.
you're like, oh, I got surgery, now I'm gonna give you this so you know how to
Well,
avoid.
maybe they did have the MRI and they knew you didn't have the bulge disc. So
Oh, so they thought it was.
So maybe it
Yes,
could be
we
something
thought-
else. Yeah,
it's to stretch a little bit.
maybe. Lose weight. Yeah, good. All right, so here are the dermatomes of the lower limb. And you can see how all of the lumbar and sacral level dermatomes originate in the low part of the back and then extend down the lower limb, and to a certain extent kind of spiral around the limb a little bit, particularly in this anterior view. You see how L3, 4, and 5 are kind of spiraling around the limb. I think in the study guide, I use the analogy of like the stripes on a candy cane. I mean, not exactly, it's not much of a spiral, but it does go about 180 degrees around the lower limb. I don't expect you to memorize the dermatome pattern, and I'm not going to give you nerve tracing questions like I did with the upper limb. So I'm not going to stick a pin in the pinky toe and have you trace it back to the spinal cord or anything like that. But I do want you to be just sort of generally familiar with the fact that there are these dermatomes that extend, the whole length of the lower limb from the low back all the way down into the foot. All right, so that's it for today. So see you in lab shortly.
Why is it called sciatica? Is it because the sciatic nerve is?
Because all of these nerves that are being impacted are branches of the sciatic nerve. Yeah.
I looked over and you were like,